My name is Tzu-Fei Wang, and I'm a adult hematologist specializing in thrombosis at the Ottawa Hospital in University of Ottawa in Ottawa, Canada. I have the distinct pleasure to have this roundtable discussion with Dr. Jonathan Coutinho, and I'll let Dr. Coutinho to introduce himself first.
Yes, thank you. Thank you very much. It's a pleasure to be here. So, my name is Jonathan Coutinho. I'm a stroke neurologist from the Amsterdam University Medical Center in the Netherlands. Clearly my expertise is stroke. So I see a lot of stroke patients in my daily clinical routine.
Thank you. Great to have you here. So, based on what we know about congenital factor 11 deficiency, factor 11 seems to be more important in the process of thrombosis than hemostasis, which could be an ideal target for anticoagulation. So, factor 11 11A inhibitors are therefore being developed and actively investigated in many phase 2 and now phase 3 clinical trials as novel anticoagulant options. There are many types of factor 11 11A inhibitors working through different mechanisms including monoclonal inhibitors, small molecules, and all of which work on reducing the levels of factor 11. So we'll start with Dr. Coutinho. We'll start with a few questions about first, what do you think the unmet needs of neurology patient in regards to the current anticoagulant therapy?
Yeah, I mean, clearly there are a lot of unmet needs in stroke neurology, but if you're, set aside the acute reperfusion therapy, right, which is of course also a big unmet need, and you're talking about your patient has had a stroke and you want to prevent them from having a new stroke, then the difficult balance to find is you want to be on the one hand, you want to be as efficacious as possible. So you want to reduce that risk of recurrent stroke and any other recurrent thrombotic event for that matter, as much as possible. But at the same time, especially in neurology, we're always afraid of bleeding, major bleeding, especially intracerebral hemorrhage, right? I mean, so far, any attempts to reduce the risk of recurrent stroke generally comes at a cost of an increased risk of major bleeding, again, especially in the brain. So that trade-off between reducing thrombosis and at the same time not increasing your risk of bleeding too much, I think that's a very big unmet need in stroke patients.
Yeah, definitely. What do you think? I think there are quite a few anticoagulant trials really particularly focused on the stroke patients. Could you give us an overview about some of those pivotal trials and what's the limitations of the currently available clinical trials?
Yeah, I mean the older trials that are of course with aspirin, right? I mean clearly aspirin is a go-to treatment for these patients, and then over the years improvements in antiplatelet treatments have become available. While I think now most of us, especially after the point trial, will give dual antiplatelet therapy for a short period of time, so usually for about 3 weeks, where you combine aspirin with clopidogrel. And then most of us, there's a kind of different approaches to this, but most of us will switch off the aspirin and continue with clopidogrel for an undetermined time. I would say that's probably now the go-to treatment in most countries in the world. And of course, there are exceptions, and sometimes a patient doesn't metabolize clopidogrel in the optimal way, and then you need to look for alternatives. But again, I think that's what happens in most cases. Of course, if we're looking at non-cardioembolic stroke, in the case of cardioembolic stroke, which is mostly, of course, in the setting of atrial fibrillation, the treatment is quite different, and it's always been anticoagulation, and for a very long time, the go-to treatment were vitamin K antagonists, so mostly warfarin, although in my country, in the Netherlands, we tend to use a different type of VK, acetaminophen. But basically they all work the same way. And then with the introduction of the non-VKA oral anticoagulants, or the direct oral anticoagulants, the DOACs, we now see a clear shift towards the use of DOACs, for the most reason because they are slightly safer, right? So again, that balance between reducing the risk of recurrent events, recurrent ischemic events, while not increasing your risk of bleeding, that balance in the patients with cardioembolic stroke is a little better for the DOACs, which is now that we've pretty much switched to DOACs for this indication. but there's still quite a lot of room for of improvement, I think.
Okay, great. So, what do you think the Factor 1111 inhibitors can address this unmet needs and to potentially change the therapeutic landscape?
Yeah, I mean, it's. I think we're gonna have to wait and what these trials are gonna show, right? We don't
Mm,
really know, but the big promise is that the idea is that factor 11 plays a much bigger role in the thrombosis than the hemostasis pathway, and in that way, we hope that it will reduce the risk of recurrent ischemic events without or with only very mildly increasing the risk of bleeding. Obviously, the best case scenario is that it only reduces the risk of new thromboembolic events without having any effect on bleeding. Now, I must say, and I think it's interesting to have a discussion with a hematologist, like we've heard this story before in neurology, right? So we're always a little bit skeptical because it's of course the holy grail, and it clearly is. But we've thought before that we would find that holy grail. So I would say we're going to have to wait what the data shows. But the data that we have so far from animal models and also from the like the genetic models in a way to say, like we know that clearly seems to suggest that that paradigm may be true in this case. So I think what we're looking for is, for now, mostly it's going to be in the case of non-cardioembolic stroke, an add-on treatment, so another antithrombotic agent on top of the routine antithrombotic agent. So in most patients, that will be a dual antiplatelet and then with the factor 11 inhibitor. And then after a few weeks, you switch to single antiplatelet therapy with the factor 11 therapy. And I think that we're going to have that's what these phase 3 trials are looking for. And we're going to have to see if that's the way to go indeed in the end.
right. Yeah, I guess I can totally understand the skepticism because I'm not a stroke neurologist, but I understand that it's not the lack of trying. There are, some large randomized controlled trial in assessing DOAC for non-cardiac embolic stroke, but unfortunately, really have not shown benefit and only show increased risk of bleeding in this pretty vulnerable population.
Yeah, and I would say it. I mean, I'm not sure if skepticism is the right word. We're more of a wait and see profession,
Hmm.
I would say, right? I mean, in all
Right.
honesty, I remember those trials in what we call the ESUS population, right? So the
Yeah,
embolic
yeah.
stroke of undetermined source, and the DOACs were tested in these patients, and I think a lot of stroke neurologists, me included, expected those trials to show the DOACs to be superior, which they just weren't, right? I mean, sometimes the data leads you to something else than your baseline hypothesis. So I wouldn't say that we're skeptical, but we're a little careful, I would say.
Right. Right, of course. Would you mind I think there are some phase two trial on the factor 11 patient for the stroke population. Would you mind summarize or maybe introduce a few important one that you think that's been shown so far?
Yeah. So I think the two important ones are the ones with milvexian and with asundexian, so both oral factor 11A inhibitors. I mean, both clearly were not powered for efficacy, right? And these were phase two dose finding studies. And I think what they it depends a little bit how you look at it. If you look at the predefined endpoint, which was a composite endpoint of new ischemic stroke and covert infarcts on brain MRI, the trials did not show a benefit of the factor 11 inhibitors. So they did not show a reduction on that end. Again, you may question if that's something that you would expect to see in a phase two trial. Um, but that wasn't seen. At the same time, there was no increased risk of bleeding. So that's on that side. That was, of course, reassuring that we didn't see that. And then there were, for instance, in the asundexian study, there were some post hoc analysis which were definitely interesting from, I would say, a hypothesis generating point of view, that if you look towards the patients with atherosclerosis, so non-cardioembolic and non-lacunar stroke with signs of atherosclerosis. So that's a specific group. It's not a small group, right? But it's a quite specific group that in that particular group, there did appear to be a signal of a reduced risk of ischemic stroke and TIA, so combined. So I think that was a hopeful signal. But again, um, maybe that's the theme. We have to be a little bit careful because that was a post hoc analysis, right? So not a pre-planned analysis. But based on that, and there's also, I would say, a plausibility towards those findings. That's also how the phase 3 trial for asundexian was adapted, which is the oceanic stroke study, where there's now more focus on this group of including these kinds of patients. Those are the two phase 3 trials that most people will be looking for in the non-cardioembolic stroke is the one with asundexian and milvexian, and I don't know the exact numbers at the top of my head, but both are aiming to recruit around, I think, 10 to 15,000 patients with non-cardioembolic stroke, and those are the phase 3 trials that will definitively show if the hypothesis is true. Do we indeed reduce the risk of recurrent ischemic stroke without increasing the risk of major bleeding? That's the big question.
Sounds great. Sounds very exciting. So lastly, would you like to kind of summarize, is there, how can hematology and neurology maybe better collaborate in the future, and maybe summarize in a few sentences for to round up this discussion?
I mean, I think there's a lot to learn from each other, and I find this that we have a weekly meeting. So just this is my own experience. We have a weekly meeting where we come together with stroke neurology, cardiology, and hematology, and we discuss cases that are brought in from one of these specialties. So it's usually residents or junior physicians that have issues with these patients that are at the intersection of these three specialties. And in all honesty, it's one of the best meetings I go to every time, and there's always a lot to discuss. I learn so much, and I think the same goes for my colleagues from hematology and from cardiology. Just because you have such a different background, if you have such different expertise to bring to the table, that with every case that's presented there, it truly I learn again, because I mean clearly hematologists they have a different knowledge background, but also the way they apply that knowledge. So yeah, I think there's a lot to learn, especially on the per case basis. So if you don't have these kinds of meetings, I highly recommend that you introduce them. They're very good. Also good for the residents.
Yeah, that sounds great. um, yeah, so it's yeah, summarize. So thank you, guys, for really tuning in and listening to this roundtable discussion. Is there any last kind of um, wisdom that you would like to share before we close?
I'm not sure if it's wisdom, but I can tell you, like many people, I'm so anxious to learn the results of these studies, right? And I really hope that the hypothesis is proven true and that we can really add a novel therapy for these patients in the chronic phase. I think in stroke neurology, maybe that's the last remark. In stroke neurology, all the attention has been focused on reperfusion therapy and for the last years, right? And that's not without a reason, because there's been huge successes in that field. But that doesn't mean that we should forget about what happens after that acute stroke and how to prevent new events. And this hopefully marks a new chapter in that story.
Definitely, yeah. We're all very anxiously awaiting for the phase 3 study.